Recording. Okay, let's review. Let's review the knee joint again, and then we'll talk about the movements of the knee joint. Right? Knee joint is formed by two true bones. Two true bones. This is femur, and here is tibia. Tibia, and here is femur. These are true bones, and there is another bone which is sesamoid bone, which is patella. So basically, is knee joint is a mixture of two joints, right? Right. There is a articulation between patella and femur called patellofemoral joint, and there is an articulation between femur and tibia, tibiofemoral joint. So basically, knee joint is a complex of two joints. We call it as knee, right? And it is one of the most complex joints in the whole of the body. Most complex. And at the same time, it is not congruent. That means femur and tibia are not fit together well. So it is a weak joint. Relatively, it is a weak joint. Right? This is some basics. Coming to the knee joint, it transmits loads, facilitates positions and movements of the body, aids in the conservation of momentum, and provides the necessary movement for activities involving the leg. So the basic things are load bearing and load bearing, first thing. Second thing is locomotion, right? And the knee joint sustain high forces and movements and is situated between the body's two longest lever arms, the femur and tibia, making it particularly susceptible to injury. So the lever arms means this is pulley, this is right, the mechanism, lever mechanism, lever mechanism. Somebody unmuted themselves, please mute yourself. So this is the largest lever, and this is also very largest because these are long bones. Because of the knee joint is placed between these two largest levers or two long bones in the body, it is more susceptible to injury. Not only that, because it is also not congruent. That means it is somewhat weaker relatively. So it is more susceptible to injury. But in spite of this susceptibility, knee is reinforced by muscles, tendons, ligaments surrounding it, giving it stability. In the yesterday class, we talked about the stability. The stability of the knee joint is given by the muscles, the tendons, ligaments, and the surrounding structures. Okay, coming to the articular surfaces. Articular surfaces are the two condyles and intercondylar notch posteriorly are the articular surfaces in the femur. In femur, condyles, both medial and lateral condyles, and in tibia, medial and lateral condyles, and in patella, posterior articular surface of the patella. You have to observe that in the movements of the knee joint, especially during flexion and extension, this is extension and this is flexion. So in the extension, that means when when the angle between posterior thigh and tibia is increased, okay, reduction is flexion and increased is extension. It is called as extension. So in the extensions means mostly foot is on the ground, that means we are on erect posture. So erect posture means we are bearing, knee joint is bearing the load, okay, weight bearing stays. So in the weight bearing, the articular surface is flat. There is so much of articular surface, okay. But in flexion, that is when the angle between the posterior thigh and tibia is decreased, that means when the leg is flexed, or when the knee is flexed, the articular surface is round, okay, not that congruent, only point of contact is round. But whereas in the load bearing stage, the articular surface is flat, thereby increasing the surface of contact with the tibia. So there is so much of contact with the tibia here, okay, there is less contact in tibia, so that it can bear the weight in extension, during extension. When we are in erect posture, okay, due to the change in the articular shape of the articular surface, that means not a dynamic change, but because of the condylar area articulation, so it becomes flat, whereas in flexion it is just round, because you don't have to bear the weight of the body. You have to remember that, okay. That is regarding femoral condyles, because the contact is with tibial condyles from femoral condylar aspect, right? Okay. From yesterday we are talking about popliteus. This is the popliteus muscle, if you remember correctly. We have already covered this, okay. This unlocks the knee joint, that was also covered. So the insertion is on lateral condyle of femur, okay. It traverses via knee joint. So while traveling through knee joint, it has uh, connection with lateral meniscus. So lateral meniscus moves along with popliteus, right? You have to remember that. Who is drawing those things? Who is drawing those things? ఎవరు డ్రా చేస్తున్నారు? మీరు కూడా డ్రా చేయొచ్చా? ఐ డోంట్ నో దట్. ఏం యోగేష్, పార్టిసిపెంట్స్ కూడా డ్రా చేయొచ్చా?
చేయొచ్చు సార్.
చేయొచ్చా? మరి ఎవరు చేయకండి.
తెలియదు సార్ ఎవరు చేస్తారు.
ఓకే ఓకే, ఎవరు చేయకండి, నేను చేస్తాను సరిపోతుంది కదా. ఓకే, కమింగ్ టు ద ఇట్స్ నాట్ చేంజ్. ఓకే, కమింగ్ టు ద menisci. Okay, there are two menisci, lateral meniscus and medial meniscus. This is medial meniscus and this is lateral meniscus. So lateral meniscus is oval in shape because lateral condyle is oval in shape, whereas medial meniscus is somewhat circular. అంతేనా? రివర్స్ చెప్పినా? రివర్స్ చెప్పానా? వెరీ గుడ్,
రివర్స్ లో చెప్పారు.
వెరీ గుడ్. So this is oval because anterior posterior diameter is more in lateral meniscus, whereas transverse diameter is more in lateral meniscus. Okay, so you have to know these things, but remember or observe, lateral meniscus is with popliteus. We have just discussed that, right? It is attached to the popliteus ligament. Okay, you have to remember that. Whereas medial meniscus is not attached to any tendon, but medial meniscus is attached to joint capsule. Okay, whereas lateral meniscus is not attached to joint capsule. Okay, joint capsule, here it joint capsule is free from lateral meniscus, whereas joint capsule is attached with medial meniscus. That is why lateral meniscus is more mobile. Okay, whereas medial meniscus is more stable. Okay, that means lateral meniscus is more mobile, means more prone to injury. Okay, okay, so you see there is transverse ligament of the knee. Okay, this is only present in 40% of individuals. Okay, so it is the connection between anterior horns of medial meniscus and lateral meniscus. Okay, now okay, that is regarding medial meniscus. And when we discussed about medial meniscus, when medial meniscus lateral meniscus, lateral meniscus cruciate ligament. Okay, there is some bands go from lateral meniscus to the femur, right? Okay, posterior to the cruciate ligament. So if these bands are anterior to the cruciate ligament, they are called as anterior meniscofemoral ligament. Okay, if they are posterior to this, posterior meniscofemoral. So this is posterior meniscofemoral ligament. Okay, and this is posterior cruciate ligament, PCL, posterior meniscofemoral ligament, right? Okay, I think everybody is clear on this. Understood?
Yes,
Reply
sir.
me. Okay, okay, okay. Coming to the capsule, joint capsule. Okay, joint capsule is attached to the articular, all the margins of the articular surface. That means this is articular surface, so it lines all the articular surface of, this is the femur and this is tibia. Okay, all the articular surfaces, margins of the articular surfaces plus superior and inferior aspect of meniscus. Okay, you have to remember this, meniscus. So superior and inferior aspect of menisci along with margins of the articular surfaces. So the joint capsule, so this is joint capsule, not the joint capsule, but synovial membrane, not the joint capsule, synovial membrane. Okay, you have to remember that. And here clearly observe, this is the synovial membrane, means joint articular cavity, articular cavity. You see the synovial membrane, this is menisci, okay, superior aspect and inferior aspect. This lines menisci along with articular surfaces, okay, the tibial articular surface, femoral articular surface, but it also lines the menisci. What you have to observe is synovial membrane does not includes the cruciate ligaments. Okay, that is very important, because that means cruciate ligaments, though cruciate ligaments are intracapsular, they are not intra-articular. That means they are not within the synovial membrane, but they are intracapsular because joint capsule will be there. Okay, they are within the joint capsule and they are within the joint space, but they are not within the that means uh, let me draw, this is, okay, this is joint capsule. Okay, pretend that this is a joint capsule, and the green one is joint capsule and the green one is synovial membrane, right? Here are cruciate ligaments. That means cruciate ligaments are intracapsular, but they are not intra-articular because synovial membrane does not include cruciate ligaments. Okay, that is here. Here it is represented by like this only. Okay, okay, you have to remember that. And also the synovial membrane is fringed. He uses the word fringed or margins of infrapatellar fat. Okay, infrapatellar fat. In the superior aspect, they forms alar folds. Okay, they forms alar folds, which that means, look at this picture. These are alar folds. Okay, superiorly before, because the infrapatellar fat pad is posterior to the patellar ligament and anterior to the synovial membrane. Because of the fat, synovial membrane invaginates into the synovial cavity. That is called as alar folds and the superior aspect. In the inferior aspect, the invagination is more acute and it is called as uh, infrapatellar synovial fold. Okay, infrapatellar synovial fold. So that is those are some aspects, and also you have to observe there is some synovial fold here, right, within the popliteus tendon, under popliteus tendon. Okay, does everybody observe that? Okay, observe popliteus tendon happen. What happened? My god, it's not responding. Running out of time. Okay, also observe popliteus tendon, and under the popliteus tendon there is an invagination of synovial membrane. Okay, this is called as subpopliteal rhesus. Okay, there are two rhesus like this. This is first one is subpopliteal rhesus. Okay, in order to prevent the friction by the movements of the popliteus, because popliteus unlocks the knee joint. And there is also an invagination or infold of synovial membrane on suprapatellar versa, suprapatellar pouch. Okay, so this is first invagination and this is second invagination. Suprapatellar pouch, subpopliteal pouch. These two communicates with the synovial cavity. These two communicates with the synovial cavity. Whereas other bursae may or may not communicates with the uh, synovial cavity, but these two, popliteal, subpopliteal rhesus and suprapatellar pouch under the uh, tendon of quadriceps surely communicates with the joint space. That means articular space. Then, okay, this is the representation of uh, alar folds. You see, so the joint capsule is reflected inferiorly. Okay, this is reflected inferiorly. This is patellar articular surface. Okay, so these are alar folds. Okay, observe them, and suprapatellar pouch, alar folds, infrapatellar pad. Okay, and this is colorful representation. You see, alar folds. Okay, same diagram, and you see this is the mid-sagittal section of femur. This is the joint cavity. This is the joint cavity, articular cavity. Okay, you see, observe. Suprapatellar bursa is continuous with the joint cavity. You have to know that this is menisci, and you see this is, hello, don't unmute yourself. This is infrapatellar synovial fold. Okay, the white one. Okay, let me draw that by green, no green, yellow. This is okay. That is infrapatellar synovial fold. Okay, observe that. So there is acute invagination into the joint cavity. Okay, you have to do that. Coming to the ligaments, the knee joint is further reinforced because of this, because of the weakness of the knee joint. Knee joint is further reinforced by ligaments. Okay, ligaments give uh, strength and stability to the knee joint. Okay, if this is the knee joint, okay, there are ligaments, they are called as collateral ligaments. Two collateral ligaments. Okay, medial and lateral, and there are retinaculum, medial and lateral, and in the posterior aspect, okay, there is oblique-popliteal ligament, okay, from semimembranosus. Thickening of the semimembranosus fascia is oblique-popliteal ligament, and many more. Okay, okay. You see, this is patella. This is patellar ligament. Okay, patellar ligament is continuous with the capsule and thickened medially and laterally on the surfaces of knee joint to form retinacula. Okay, lateral retinacula and medial retinacula. You see, within the retinacula also there is some distinction, transverse and longitudinal. This is longitudinal, lateral longitudinal patellal retinaculum, and deeply there is transverse patellar retinaculum. Okay, you have to observe that both medial and lateral uh, transverse and longitudinal patellar retinaculum are there. Okay, so this is medial longitudinal patinacular, and under surface of medial longitudinal patellar there is transverse patellar retinaculum, right? Okay, and then this is the posterior aspect of the knee joint. Here is oblique-popliteal ligament. Okay, this is oblique-popliteal ligament because it is a thickening of fascia of Semimembranosus, right? Semimembranosus. Remember this. Semimembranosus. It covers posteromedially. Okay, it supports the knee joint posteromedially, and laterally you see subpopliteal recess here. Subpopliteal recess. This is the popliteal tendon. There is subpopliteal recess because this is the joint cavity itself. Okay, synovial membrane, subpopliteal recess, and there is arcuate popliteal ligament which supports posterolaterally. So here oblique popliteal ligament supports posteromedially, whereas okay, I'll call again.